Well, I think we are all looking forward to presentation from our fine colleague, wonderful supporter for KRF, Professor Frank Niessen. Please come on up.
Well, after all those talks today, I feel humble and very honored to give this talk. I don't have that much of laboratory background, so I give a little bit of a different talk. Does it work? Of course it is not working. Oh, it's on, yeah. Michael told us about him, and well, let's do it different. Let's do it different. Like this? Okay, with this one. It's not working. So what will I tell? Yeah, is it working? Okay, good. He was known for his interest in rare skin diseases, and maybe keloids are a rare skin disease, but when I see so much patients, I don't know if it's such rare skin disease, but he was interested in that. And mainly also in the basics, in the fundamental relationship between cells. But also, he was very inspired by his patients and looked at his patients for inspiration for his research. And that's what I will talk about as well. And I think that those patients suffering from keloids, they suffer from threats. And before I come to keloids, I want to tell something about my own science story. And who am I? A father, and you've seen her, my beautiful daughter, entertaining you and smile at everyone. I'm a holistic plastic surgeon. I will tell more about that. An innovator, educator, a scientist, and alchemist. I work in my own private practice. It's called Mitsu. It's 3 in Japanese. It's an holistic practice. And I work here in the SCAR clinic as head of the SCAR clinic in the University Hospital here around on the other side of the road. I like traveling. I like shoes. But most of all, I like to find a solution against keloids. Because although I don't think I have a big ego, but when it's regarding science, I have a very big ego. Because when I find the first solution against keloids, I'm better than you all. That's what drives me. And the first meeting in Rockefeller in the United States, there were a lot of very well-known scientists everywhere from the United States, all their own lab, and they all came up with the solution against excessive scarring. And I sat there and I thought, if they don't work together, they will never find it. And now see us 10 years later, and we haven't found it. So we have to work together. But we have to look at the patient and listen to the patient. And this was, I did my military service, I think 40 years ago or something. And these kind of patients, they come from Indonesia and they appeared with these kind of well-known keloids. And I thought, well, probably I can find something about that. Well, here I stand so many years later. And at that time in Australia, it was known that when you put silicone material on scars, that they improved. So I thought, if you can treat them, maybe you can prevent them. And that was the beginning of my PhD. And I used the breast reduction scar model to apply silicone on one side, another side at random. And I looked if, and I started to apply them at 3 days following surgery. Well, at 12 months, the applied scars were worse compared to the non-applied scars. And there was someone from Brazil. She had it was a female, and I thought she was here yesterday, the day before yesterday. And she found that you can prevent scarring, hypertrophic scarring, when you apply silicone material, but on week 2. And I started to do it on day 3. So maybe there was a difference. But fortunately, I took biopsies of those scars as well, because otherwise I never have had my PhD. And I found in my research that epidermal processes are involved in hypertrophic scarring. And I found also that in the hypertrophic scars, there were a lot more Langerhans cells. And I thought Langerhans cells, they signal mast cells, and it has something to do with allergy. And I know it was on a Saturday evening, and I found my professor. I found a solution against hypertrophic scarring. The Nobel Prize will come shortly. And he said, no. So, why come back to that? People who get operation on their heart surgery, we all know some of them get a normal scar and some of them will get an ugly scar. So in that process, where is it going wrong? What's the mechanism, and where can we fit in our therapy? And if we look at those patients, and there was in the time that we could take a lot of biopsies within one patient, and I was living in the north of Holland, and those patients, they are keen to have biopsies. So I could take biopsies, and we had normal scar formers and hypertrophic scar formers. And we looked at several things, but I will not tell you everything, but this was interesting. When you look at the macrophages, then you see that in normal scars, there are a lot more macrophages at 2 weeks. And in the hypertrophic scars at 4 and 6 weeks. And then if you look at these charts, here in the first one, you see that when you look at all the inflammatory cells, there are more inflammatory cells in hypertrophic scarring. Well, that's logical. They are red, they are raised, whatever. But when you looked at the macrophages, then you saw that there is more inflammatory reaction in the beginning of the healing and in hypertrophy later on. And that puzzled us. And I looked at M1 macrophages with CD40. And when you look there at 6 and 12 weeks, that's strange, so many macrophages. But I think those are not macrophages, those are blood vessels. So you see there is a lot more blood vessels, and that's what we find in hypertrophic scarring for sure, at 6 and 12 weeks. And yes, the day before yesterday, there was a talk of our French colleague who said that CCL2 was higher in keloid formation or in excessive scarring. But we found the opposite. Very strange. When you take biopsies at 2, 4, 6, 12 weeks and 52 weeks, that in these kind of chemokines, they are higher in normal scars. Strange. So at least there is a different inflammatory pattern. And together with the Department of Dermatology here, I thought, well, if you have a bad night of sleep for several times, then you are itching more easily. Your skin is you get more easily dimples. And what we thought is, if you put an irritating soap on the arm of a patient suffering from hypertrophic scarring or not, and you combine them, what will you find? And we found out that if you irritate the skin of someone who's getting hypertrophic scarring, and it was in the breast reduction, you have significantly more redness. And when we took blood samples, and in those blood samples we took the inflammatory cells, then what we showed was that almost in all cytokines, chemokines, that the normal scars had a higher inflammatory outcome compared to the hypertrophic scars. Quite unusual. So it became in my mind that probably people suffering from excessive scarring have a different inflammatory pathway, and that the initial inflammation is low and the later inflammation is higher. And that's the reason why you can do laser around the surgery, because it gives an inflammation and end up with a more beautiful scar. Okay, I can see you looking, where are the keloids? Well, wait. Hypertrophy is around the borders, and you have a lot of information around that. And when you know more about scars, then suddenly people come with scars. And those scars were keloids, because at that time we thought, all of us, from a keloid is an extension of a hypertrophic scar. So you have a normal scar, you have an atrophic scar, normal scar, hypertrophic scar, keloid scar. But that's not true. That's what we know now. But where's the difference? Sometimes it's quite difficult to know which one is an hypertrophic scar and where does the keloid start. And this patient told me, "Doctor, I feel it below my skin, and then suddenly it appears, it pops up. And there is absolutely no wounding before these kind of scars appear. There is no normal healing sequence. And it appears as a small inflammatory lesion, and then it pops out, as we all know. So it's not a wound, a keloid." At that time, a PhD of mine, he looked at cryotherapy. And that looked fine to do cryotherapy, but those needles are quite expensive. And I'm a surgeon, I want to have more, a quicker solution. So what we did, we found that argon is a quicker solution, more easily, more fast, but those needles are 500 euros each. So the head of my department, you saw him on Thursday, he said to me, "Is that necessary?" And then I met Michael in Copenhagen, and he said, "Well, you can do it like this also." Now, we know this all, that you can do cryo like this, way less expensive, and we can do that very easily. But if we treat those keloids, then we want to prevent late recurrences, or at least recurrences. And why are there recurrences? And what are the mechanisms? And because, like Lemon said, we do the same things almost as in the 1920s, so probably we're looking at a wrong road, that we have to go beside the road and look elsewhere. And then it comes back to the lecture, that we have to listen and look at our patients. And the first patient I came up with different ideas was the patient. He said to me, "Doctor, I read this book. It's How Not to Die. It's about what I eat regarding to the illnesses. And you have to do this diet." And it is this diet. And when I took this diet, when he did that, he had less itch of his keloids, and his keloids were at the back of his head, and they were more flexible. So this improved the appearance and the itchiness of his keloids. During COVID, I saw him again, and he changed his diet, and I had to treat him with cryotherapy because he quitted this diet. But from that day on, I experimented to tell my patients, can you change your diet? And it's, for a lot of patients, it's quite difficult, but when they actually do that, that improves the quality of their life, and they have less itch and less pain. Another patient suffering from a keloid of the ears, she was operated quite a lot of times, and she started to do mindfulness and meditations and go on retreats and things like that. And it helped her to reduce the growth of the keloid. The other thing was that people were suffering always from small lesions, small inflammatory reactions. And I told you before that it was fungal acne, and it was looking like that the keloids were same as fungi, and that made me think about of these keloids have a relationship with the microbiome. And some patients told me, if I go elsewhere, like in Suriname, and I got a fungal infection, besides my fungal infection, the keloids grow. So I thought, what can I do? I can let them apply antifungal creams on their keloids. And some of them, they improved in reduction of their complaints, but not all of them. And now we know that the microbiome is different between keloid formers and non-keloid formers. And we also know that there are different populations of bacteria from keloid and non-keloid formers and from the keloid and your normal skin. So that's why I advise my patients to have a different diet if possible. Okay, in my private clinic, I see a lot of patients with breast implant illness. Means that if you have breast implants, foreign bodies, that the illness can be fatigue, joint pain, muscle pain, night sweat, depression, all kinds of complaints. Very strange and not known why. And we did research on them, 150 patients, and we found out that they were more sensitive. And what means sensitive? More sensitive to noise, emotional sensitiveness, more sensitive to coffee, like they were more sensitive. And there was a correlation between the sensitivity and the amount of complaints. So I thought, is there a difference between a keloid former and a non-keloid former regarding their psychology? And those patients, in my opinion, asked themselves, I asked all the patients last year, they are more sensitive to emotions, to environment and things like that. And the other thing is that it seems to have a high achievement level. At least they're always in their head. They're always in fight and flight. They're always on. And it seems that they like to feel threatened. And is it true that patients suffering from keloids have a different psychology? Are there traumas in their youth? Are there different coping strategies of stress? Are they different in that regard? And when you look at the literature, it's known that psychological stress influences the recurrence rate of keloids negatively. And what's also found is that there is an association between bipolar disorders, anxiety, schizophrenia, and post-traumatic stress disorder. So there seems to be a relationship between the psychology of the patient and their relation with keloid and the development of keloids. And because we are medical doctors, we are educated left brain. I make a cut and I do it in healing. I look at the data in the lab. That's all left brain. But the other side of our brain, the right brain, are our emotions. What's the feeling you have? If you feel better, do you heal better? We have to take into account that we are left and right-brained. So it seems that they are in fight and flight reaction all the time. And what do we know if you are in fight and flight? Differences in neurotransmitters appear. You have a higher form of activation and a lower GABA to suppress it. And that means due to those neurotransmitters, you have a chronic stimulation of your sympathetic system. And that has an effect on macrophages. And by macrophage activation has effect on fibroblasts. And the gut microbiome is a huge source of the suppressors, the GABA. So is there a relation between the microbiome and those neurotransmitters? Yes, there is. And this year there was a publication of the people from Shanghai that in traditional Chinese medicine, you see that there is a stagnation of qi in blood, accumulation, coagulation of flag dampness, whatever it is, incomplete elimination of toxic heat, and there, the constitutional hypersensitivity. So that's the sensitivity of those patients are spoken about. And in the Chinese medicine, there are two kinds of personality, suffering more from keloids, and they did research on that, than other personalities. So that inflammatory state will activate fibroblasts and is potentially a background of keloid formation. And that inflammatory state reduced maybe the initial inflammatory state I saw in my hypertrophic scarring, because when you are continuously in a hyperinflammatory state, it reduces the reaction of your inflammatory cells. And what about the threats? If you have an open wound, you can get infection, you will lose fluids. So what the body closes this to reduce the threat. And if it's closed, there can be a reaction to reduce that inflammation and start remodeling. But if you're, as a person, are continuously in a hyperinflammatory state, what effect can have that on the normal resolution of the inflammation during wound healing? Tension, that's a kind of a threat as well. And then very strange, in the middle is no same tension, but the scars are different. And if you treat that, you have to take into account that you stitch it in such a manner that you have less tension on the wound edges, and then the scar will improve. We know that the threat of the microbiome and microbiome is there. And that's what I told you already. So hopefully it can suppress these developments. The other thing is that the gut-derived microbiota are involved in the development of keloids as well. And we are known that stress and the inflammation in a person itself influences the gut microbiome. Another thing was found that in the keloids, you have abnormal Schwann cells. They are more itchiness, they're more open to activation. And that can be the cause of the itching, which is continuously there. And that's a threat as well. Okay, taken all together, patients suffering from a chronic sympathetic activation have an immune dysregulation. Chronic inflammation, more macrophages, more M2 macrophages. They have less antiviral and cytotoxic activity to reduce the threats of the microbiome. More allergy, there's more depression, burnout, neurodegeneration, hyperarousal, anxiety, sleep disturbances. And we know that if you sleep not well, then your immune system is suppressed also. So what I advise my keloid patients is turn yourself off. And that's what we do in our clinic. Easy, relaxed. We have a special plan for that. And the first thing, how you can reduce your dopamine and serotonin levels is to have a better sleep. Better sleep, no cell phones an hour before sleeping, cold, dark, no coffee following 2 o'clock in the afternoon, no dinner 3 hours before you're going to sleep, and you have a better sleep quality. Foods and supplements, I told you about that already. And the supplements, you can reduce inflammation by omega-3, vitamin D is talked about, and things like that. exercise, very important. But when you do too much exercise, it gives stress in your body. But when you exercise and you reduce your stress afterwards, that's good for a keloid patient. Mindfulness and meditation. Well, if you're always in your head, it's quite difficult to meditate. Then you can advise them to small meditation of 2 or 5 minutes. And breath work. If you have a deep inhalation and you inhale like this, you have to inhale with your lower abdomen. You inhale 4 seconds in, 6 seconds out, and that activates your parasympathetic nerve, and that reduces the sympathetic stress. Hypnosis can work. And coming back to my eureka moment about the Langerhans cells, all those neurotransmitters activate Langerhans cells. So probably there's a relationship as well. So what I think we have to take into account when we look at our keloid patients, reduce the systematic inflammation with a holistic approach. And that can be tension, that can be supplements, that can be whatever we do, but take into account that we have to do an holistic approach. And I felt honored to can give you something to think about a little bit different from the rest. And I thank you for your attention.
Thank you, Frank. Thank you very much for your wonderful presentation, opening our eyes into a totally different aspect of managing keloid patients, aspects that we don't think about. You know, this is so wonderful to learn from you. Questions from Professor Niessen? John. It's very hard, John. That's the hardest thing to do. It's one of the challenges. Remember, I listed.
How do you switch me on when you switch him off with your hypnosis?
I think no one can switch you off. Sorry.
Yes, they can.
I was right.
That was a great talk.
Thank you.
And very moving. And they're all the things we don't think about. And Juliet was very moving, and her patients. So I congratulate you for being holistic. And it's fabulous to have a surgeon who has the time like you to give thoughts to all these other problems that these poor people suffer from. Really great pleasure to hear you. Thank you.
Yeah, thank you.
I don't want to smooth you too much, but
and it's especially these patients, we asked them, and that's why we came about this idea that there is something different in their psychology and their systemic inflammation, and has maybe something to do with the neurotransmitters. Yeah.
Great. Any other? Please go ahead.
Thank you for your talk, and congratulations on all these things. My question is, I mean, there are so much more things we haven't thought about. Also, I mean, Ayurvedic medicine, doshas, whatever. In your opinion, what are you working on next to implement? Is there something what we did not discuss?
Yeah, first, what we like to try, but it seems to be difficult, is to measure neurotransmitters and relate it with the keloid disease. Because I come up with a theory, but I have to prove it. And so we try to start to get GABA out of the blood, but that was not possible in this lab. So we have to find out how we can measure those neurotransmitters. That's the next thing we want to do.
Omi, please.
Hi, sorry, based on what you both just said, when we went to India, they asked me for my medical background. And one of the things in my medical background is I was diagnosed with seizures as a kid. And apparently there's something between seizures and skin disorders. And they decided that I was atypical with my keloids for the seizures and the skin disorders. So just something to think about.
Okay, and I've seen many patients suffering from ADD or ADHD. they're always in their head as well. And they have a hyperinflammatory state also. So that's why we come up with it.
Yeah. But one thing, may I, just one thing we have to be careful, like the case of basal cell carcinoma that we discussed yesterday, all these other diseases, disorders are common. So we need to be able to differentiate. There is an incidental happening that this patient happens to ADD, ADHD, almost 20%, 30% of population in the US is diagnosed with that. Hypertension, I mean, 10, 15%, diabetes, asthma, these are extremely common conditions. And then you also have keloid patients, and then there is an intersection there.
Yeah, absolutely.
The question is there any relationship or not? And if you're going to have an impact, we need to better understand this. And that would come from epidemiological study to see whether or not patients who have hypertension and keloid, is keloid disorder causing hypertension or vice versa? And if you remember, in 2022, we presented data that actually hypertension had a protective effect on patients. Patients with hypertension had less keloids than patients who did not have hypertension. So any one of these things we pick up, we really need to assess it properly before we run with them.
Yeah, but we have to think about them.
Jonathan, please.
I wanted to ask Dr. Niessen if you could elaborate a little bit more about the microbiome. I mean, specifically, how does it affect keloid pathogenesis, and what specifically can you do as a clinician to truly alter that in a way that's more beneficial?
Yeah, I came up with this because when you listen to the patient, and then I had 3 or 4 cases suffering from a fungal infection elsewhere, and then they told me that a keloid grew. And because keloids they start with small infectious little dimples around the hair follicles, inside the hair follicles. It can be due to a fungal infection, but it can also due to a it can be due to a fungal infection, but it can also be due to a bacterial infection or a viral infection. We haven't done research on viruses as well. So it's just that there is a possibility that there is a relationship. And then I came up with case reports finding that there were keloids, fungi were found in keloids. And just last year, it was found in China that there is a microbiome is different and malaria is higher in keloids. So it's just that we have not that much funding here in our hospital, so we have to look at our patients to come up with new ideas, and then suddenly you see it pop up in the literature. And that's why I bring this kind of idea in audience like this as well. Then hopefully 1 or 2 are running with it, that in 2 years' time there is proof that neurotransmitters are involved as well. Also other in things, and probably there are relationships between everything, and that's something we have to find out. Yeah.
Other questions for Professor Niessen?
I heard you say that a keloid is not a wound.
Yeah.
And I didn't quite understand that. That's one.
Okay, because the keloids are not developing regarding the normal wound healing phases. They are in a hyperinflammatory state. They are hyperinflammation. Part of wound healing is inflammation, indeed, but inflammation resolves normally at, say, week 3. And what you see when people are operated on, that the keloid will appear later on, even sometimes like a couple of years. So it's not the inflammation of the normal wound healing sequences. It is indeed an inflammatory state. It's inflammation, yes, and during wound healing you have inflammation, but it seems that it's a different kind of inflammatory state, not following the normal wound healing sequences.
Okay, then I noticed in a lot of the videos that we've been seeing, even the first year we came, there's lots of concentration of the keloids on the chest.
Yeah.
Hardly anyone has a keloid anywhere. that it doesn't appear somehow
Well,
in the chest?
That can be due to the fact that there is a small inflammatory beginning and where you see acne, but also when you have sebum cysts, they're always on the same spots as where you develop keloids. And if the region is the cause, or the fact that when you have that small inflammation, that's the start of the keloid production, because we see more keloids in female than in male, because female are more pierced in the ears. Is it due to the fact that you're female, or is it due to the fact that the cause of the keloids is higher in female? Probably the last.
Thank you.
Any more questions? Thank you very much. So,
Thank you.
Frank, thank you. Don't go. Thank you very much. Please don't go. Thank you very much to the research and field of keloid. We truly appreciate that.
Thank you, Frank. Again, Keloid Research Foundation would like to present you with the 2026 Annual UniGito International Visiting Professorship and Lectureship in Molecular Dermatology. Thank you for all your contributions.